Well, hello everybody and welcome to another episode of GUcast. This is Declan Murphy, urologist here at Peter MacCallum Cancer Centre, joined as ever by my co-host Dr Renew Eapen, urologist here at Peter Mac in Melbourne. Morning, Renew.
Hello, Declan. It's our first podcast of spring.
Oh, it is.
It's still
spring.
freezing though.
I know. Spring in Australia.
Someone tell the weather.
Sorry to rub it into the Northern Hemisphere, but this is just coming into the sweet spot for us, isn't it?
Yeah, it really is. Nice time of the year.
Great. And we got a couple of studio guests, a couple of friends of the podcast are back to see us again. We'd like to welcome back Professor Nathan Lawrentschuk, urologist here at Peter Mac and head of urology at the Royal Melbourne. Nathan, welcome back. It's been a few months, actually.
It has. Fantastic to be back here and talking about a topic today close to my heart.
Bladder cancer, it is indeed. And before we get to Nathan and our international guests, Dr Aoife McVey, our registrar here with her occasional segment on what's happening out in social media. Oh, you've got a new name for your segment. Have you finally decided on a name for it, Aoife?
Yeah, I just thought I'd build some anticipation for the name, but was thinking Twitti-Leaks.
Twitti-Leaks with Aoife McVey.
Is that a play on WikiLeaks?
Twitti-Leaks, do we like that? If you like that, please let us know. I like that.
Vote.
At least leak is a urological word.
Yeah.
I actually didn't think
I think Twitty could get twisted around.
Lovely. So it's perfect then. We have a portmanteau, we have a little bit of subtle blah blah. So Twitti-Leaks, we need to make a jingle for you then. You deserve your own jingle with Twitti-Leaks. So what have you got for us on Twitti-Leaks this week?
So what I'd seen on Twitter this week actually came from the BURST Urology Research Collaborative. I wasn't tipped off by Viru at all to talk about this on the podcast. I have to disclaim that first of all. But they had done that paper recently in BGI on the stones, and from that they've made a risk calculator it's called Mimic, and they have another one called Identify. And on their website, it's just a calculator that you can put all of your patient information into, and then you get like a percentage chance of passing the stone and that sort of thing, and also a hematuria risk calculator as well. So I thought it was pretty good. It's nice if you see a patient in ED and you can say to them you've got a 22% chance of, that sort of thing. Helps with that consultation. So yeah, I advise people to check it out.
They're very good, BURST, aren't they? We've had them on. We did a piece about BURST and about about these young collaborative trainees who are working together in their own countries and internationally. EAU, Australians, BURST group, and they've done some nice work, Nathan, haven't they?
Yeah, they did. We on the back of BURST, we obviously started the Young Urologist Research Organisation, and in fact, Todd Manning, who was involved in the first iteration of that, was actually on that Mimic paper because we gathered the young Australians to be involved in that as well. So when that paper was published, I think it's one of the large. What it shows is the power of group thought, if you like, that you can get hundreds of trainees to actually get data, and then suddenly you've got thousands of patients of data, which is where this comes from.
Yeah.
Fantastic. Well done, BURST.
Excellent.
Yeah.
Anything else that you saw?
I'd also seen that your old fellow Marcus has got a new podcast. It's called Top Bunk, Bottom Bunk.
TBBB.
Yeah, and I started to listen to it. The first episode's actually a nice episode for women in urology. So it interviews, I think it's Dr. Jo Creswell, the female president of BOIS, and also Dr. Nadine Cole, who I think she's in charge of the urology section at the Royal Society of Medicine now. So, yeah.
And then I think Stacey Loeb for the second episode. So 2 episodes and some great guests. So they're off to a great start.
Yeah.
Top bunk, bottom bunk.
Yes.
T-triple-B, I heard Marcus introducing it as. So that's a useful podcast, T-triple-B. So Marcus being a young consultant and Sammy being his research fellow. So I think they're trying to give that sort of perspective, and they've got a very professional setup. I must say, I was very impressed from a technical point of view. They've got a good team behind them, Sanak, one of their trainees. So we'll link out to them, and maybe we'll get them on in a few weeks to give them a plug.
Couldn't help it. T, is that transperineal prostate biopsy?
We're talking bladder cancer. Sorry, no, people complain we talk too much about prostate cancer.
Yeah,
any other Twitti-Leaks?
I don't think so. Just to continue the usual Kardashian update, Kim Kardashian, I think, has joined partners with a private equity fund. So that's her next venture, and we wish her all the best with it.
Excellent.
She needs more money. More money.
Nathan, was that news to you? Do you follow the Kardashians very closely?
Thanks for updating me. I'd missed that one.
Yeah.
She left the most important one for last.
Thank you so much.
Twitti-Leaks.
Thanks, guys.
Thank you. Good to see you. Thank you. So, Renu, we better introduce our international guests joining us for this bladder cancer special. We haven't talked bladder cancer for a few months, and it's a very popular topic every time we talk about it. And so we thought we would reach out to some of our friends and influencers overseas. So it's a great pleasure to welcome Dr Neha Vapiwala, a radiation oncologist at the University of Pennsylvania, and also Dr Ashish Kamat, an old friend of the podcast as well, from MD Anderson Cancer Centre, a urologist specialising in bladder cancer. Neha and Ashish, welcome.
Welcome, guys.
Great to be here again.
Yeah, thank you.
Yeah, great to have you back. And Neha made an appearance briefly previously when we were at the APCCC in Lugano, and she came to chat with us, and she's a great opinion leader in GU oncology. She's great fun to follow on Twitter. We'll link out to her, of course. And obviously, this topic today, bladder cancer, bladder preservation, is something that we need an expert in GU radiation oncology to talk about, and we need a urologist specializing in bladder cancer. We got two of them. We got Nathan and we got Ashish. And we wanted to talk, first of all, about the BC 2001 trial, Renu, isn't that right?
Yeah, fantastic long-term results now, 10-year outcomes. So it's a great trial that's just been published in European Urology, and great editorial to follow that up, and it'll be wonderful to hear these guys talk about it.
Yeah, and we've seen both of you tweet about this, and of course this was a landmark trial when it was originally published in the New England Journal of Medicine, a randomized trial exploring the use of chemoradiotherapy for bladder cancer. Kind of, I suppose, defined where we are with that now. So Ashish, I've seen you tweet about this, and can you just give us your overarching comments on this update to BC 2001 published in European Urology? I should say Ashish is also an associate editor at European Urology Oncology.
Yeah, no, so Declan, first of all, again, thanks for having me on the show, and thanks for the opportunity to talk about this very important topic. When it comes to bladder preservation, the pendulum kind of swings each way. It goes one way where people are completely against bladder preservation, then they go completely for bladder preservation. And we need trials such as these to kind of inform our decision making. What's nice about this report is that it's long-term data of a trial that, as you rightly mentioned, was a landmark study, and essentially cements the data, right? So it's 10-year follow-up. It cements that chemoradiation should be standard of care, is standard of care at this point. And again, you can look at the nuances. I'm sure you will ask us about the nuances between, the short-term data, the 2 to 5 year data, and the 5+ year data. But essentially, I think this is good to see. It should allay the fears of some of the people that thought that the follow-up of the original report was too short, which it was, even though they reported in multiple presentations at different meetings. But seeing this in print always is useful.
That's interesting, isn't it? Because, when it comes to muscle-invasive bladder cancer, bladder preservation is often seen as a bit of a dirty term. And I think we need data like this to really cement the fact that we can offer still a curative option for patients with bladder preservation.
Yeah, I think so. And Neha, your comments on this update, and of course the trial was not comparing with surgery. We can talk about that in a few moments, the role of radical cystectomy, but this was a very nice trial comparing the optimization of bladder preservation, radiotherapy alone versus radiotherapy with chemo. But yeah, your thoughts, your take-home messages.
Sure. Well, and again, thank you, friends, for inviting me. I think if I had one little complaint, it would be that you didn't send me a suit of armor to protect me as you invite me to a room full of brilliant urologic surgeons. But that's okay. We're all friends here, right? So
absolutely.
And it does rather, I think, stand to be an important point that we did not have a comparison to cystectomy. That's right. The focus of this trial, exactly as Ashish said, is cementing what we have already established in practice, which is that the combination of chemotherapy and radiation, clearly is the preferred way. And in this case, although local regional disease was the primary endpoint, there were several other parameters in which there clearly was the benefit to the combination. And I would just say, as a radiation oncologist, and I hope I don't put any urologists to sleep with this, but mitomycin, 5-FU, and radiation, we've long used this combination. We've used this for head and neck cancers, for the treatment of esophageal, for anal and cervical, and so primarily in the world of squamous cell carcinomas, and a lot of in vitro data showing not only the additive effect of 5-FU and mitomycin to radiation, but a super additive effect, and the idea that this radiosensitization and perhaps also the cytotoxic cell kill that happens, that one can take advantage of that in a multitude of cancers. So seeing this potential the potential of this combination be, shown to fruition with long-term data in the muscle-invasive bladder cancer setting is very fulfilling. It's important, as you said. The landmark study was the 5-year study, but we all wanted to see these long-term data, and so it's again reaffirming what we know. And the one other point I would add is these are true patients that we can relate to, that we see in clinic. Not all of them had resection. Not all of them had complete tumor resection. Not all of them are a young, fit age. And so I think that's also particularly useful to those of us in practice who are looking for data that can be applicable to our patients. Yeah,
that's a great point. And Nathan, often we see these patients with bladder cancer who advanced stage, lots of comorbidities, and often, they're not candidates for things like platinum chemotherapy. So this combination of mitomycin and 5-FU is really useful, isn't it?
Absolutely. And that was a really good point just made. Of course, we know that chemoradiation is standard of care for those who can't have a radical cystectomy. We would confirm that from this trial. But you're right. If you look at the patient cohort, it was older. It was patients who weren't fit in general for cystectomy. I think the really interesting group to target are those where perhaps they're a little bit younger, where maybe does this bring into play clinical equipoise, where you can genuinely say, well, you know what? I'm not sure. Maybe radiation chemo is good. You'll keep your bladder. Maybe cystectomy is good. So I think we know that there's this clear group of patients who've got obstructed ureters, significant lower urinary tract symptoms, etc. They're not going to be suitable for this. But for me, it's about the middle group, which is where we have the clinical dilemma where we'd like to do bladder preservation, but we're not sure. I think the devil's in the detail. When I was in my SUO fellowship in Toronto, we had a very sophisticated program there for chemoradiation. And in fact, I think, and this, even going back to the original paper, I couldn't get a feel for this, was the 2 points again brought up. We really wanted complete resection in these patients before they had chemoradiation as a preference. But also the radiation oncologists used to come to our cystoscopy suite, and halfway through the chemo cycle, we would see who was progressing and who wasn't. And then we would stretch some of those patients to go on and have salvage cystectomy. So I think there's a little more to this than just yes or no. I think there's also the subtleties of selecting patients even mid treatment cycles to say, well, actually, we will change course here if the chemoradiation's not working. So I think I'd be interested to hear what our other two guests have to say about that as well.
So, Nathan, you very succinctly put together the natural history of the evolution of chemoradiation for bladder cancer, right? Because when it first started out, the selection of patients was somewhat what was reported in the study, a solitary tumor, well-selected patients. Again, there were real-world patients in this trial too, but selection criteria for bladder preservation with chemoradiation was very, very restricted. And it was done so mainly because, people didn't believe. When we say people, urologists didn't believe in chemoradiation. So the folks that designed these studies and these trials selected patients with no CIS, solitary tumor, complete resection, no obstructed ureters, et cetera, et cetera. And that's the majority of the data. That's in that patient population that chemoradiation has shown to be very, very effective. Over the course of years, of course, we and others have learned that you don't need to be as restrictive. You don't need to have just a solitary tumor. It doesn't have to be tiny. You can also treat some patients with CIS. You can also treat some patients with obstructed ureter so long as you resect the tumor. And more importantly, you don't need to necessarily do a complete radical TUR. A deep bulking TUR is still very, very important, but you don't need to do that radical TUR that we used to do where you'd actually go almost down to fat and have no tumor left in the bladder. Because to be honest with you, if you can do that in a patient, many of them you can just observe, right? They don't need radiation afterwards. You could just do a radical TUR. So I think you very well put it. The evolution of our recognition of which patients we can use chemoradiation in as a viable option for curative purposes and not just palliative has evolved over time. But if you look at the strict definition of sort of which patients will fall into the chemotherapy or chemoradiation realm, it still today represents 10, 15% of patients that we see in our clinic. So in the well-selected patient, absolutely chemoradiation, no question. It's that gray zone in between, since we're talking about potential comparisons as to who would be better served with bladder preservation, with chemoradiation, with radical TUR or partial cystectomy, or with cystectomy. That's the question that I don't think anybody has the right answer to yet.
And maybe over to you, Neha, to talk about the surgical aspect of cystectomy. You did outline the 5-year cystectomy rate in the paper. Can you go over those figures with us? What was the rate for those who had chemoradiation and for those who had just radiotherapy alone?
Yeah, because it strikes me that, you forget that 5 years later, it is a successful strategy. The vast majority of people are keeping their bladders intact. And I think it was 14% cystectomy rate for the chemoradiotherapy versus 22% for just radiotherapy alone. So, I mean, we're all using chemoradiotherapy for these, but like 85% of patients are keeping their bladders, Neha. That seems pretty good, doesn't it?
Well, exactly. And, I think, again, exactly as you said, the 14 versus 22% salvage cystectomy rate, the hazard ratio, 0.61. When they adjusted for the other prognostic factors, 0.59. So we could just, say, in terms of recurrence-free survival, that is incredibly impressive. And again, even though bladder cancer-specific survival was only borderline significant, I think the feeling that you have patients who actually do have functional bladders, and this is where, again, patient-reported outcomes as well as physician-reported toxicity is incredibly important. And I think it's pretty remarkable, actually, when you look at the 5-year report compared to the 10-year report that was just published, the rates are actually somehow favoring chemoradiation, if you will, in terms of actually cumulative grade 3-4 toxicity. So, I think, again, in a patient who does not have cystectomy as an option or for whatever reason has not chosen to pursue that, I think this is incredibly reassuring to those of us who want to be able to provide these patients, not just the cancer control that, of course, we're seeking, but leave these patients with something to look forward to, some quality of life to be able to spend their years. And I think it is important that we talk about their remaining years, because the overall survival in this population at 10 years is low, right? Overall, these are patients who are dying of other causes, and we have to think about how these treatments may have contributed to these other causes. I think attribution of cause of death is one of the hardest things in the world, if not the hardest. I think we do a good job of it, but we do the best we can. But I never take for granted that the long-term toxicity of radiation and certainly chemo together must always be valued. And so in this case, having patients report in this study that they are happy with their bladder function, I think is a key take home as well.
It's also important to note that I think half the patients who had local tumour recurrence didn't have a cystectomy, and that may be because they were too comorbid and so on. But there was still a significant number that was recognised that they did have local recurrence rather than systemic, from my reading. The other issue is, and this may come as a shock to you, most urologists think that the RTOG toxicity scale is a little bit soft. In the Clavian Dindo, you spell someone's name wrong and it comes up as a grade 2 complication. The RTOG, you've virtually got to have the patient, having a blood transfusion, intubated in ICU. And is that grade 2 or 3 toxicity?
Fair, very fair, very fair. And that is, I always do take that with a grain of salt. And that's where I know they use the lensoma as well. But you're right, it's all in the scale that one uses. And of course, it's all in the eyes of the beholder as well. I think we've all had urology patients who come in for follow-up and they're, having all sorts of issues. And when you ask them, how much does this bother you? They might say, oh, not at all. And then you have somebody else with the minimalist of symptoms, and it bothers them a lot, right? So there's so many layers to this, but you're absolutely right. The scales that we use, are very important in our interpretation.
Which is why the quality of life is the single most important thing, because one patient's symptom will cause no quality of life issues and the other one's devastating, So
And these patients who did end up... sorry, go ahead, Ashish.
So I just going to make a point about the cystectomy-free rates, right? Because, that's something that people often will try to hang their hat on and peg the results with. But we actually had an FDA workshop last year in November to talk about cystectomy-free rates as an endpoint for bladder preservation. And if you looked at the panel, it's an open FDA workshop. You can view it if you need to. But the bottom line was cystectomy-free rates are so fraught with biases, right? Declan, you might recommend cystectomy to patients patient A, Renu might see that patient and say, oh, you don't need a cystectomy. Let's just resect this and put some BCG in and salvage you. And then Nate might see someone and say, oh, you should have had a cystectomy yesterday, right? So who does the patient listen to? What is that cystectomy-free rate and how does it actually correlate? So it's good that we see that. The other thing to keep in mind, and again, all of us here know this, but for some of the more younger trainees that might be listening in, when you look at the percentage of patients that undergo cystectomy on any trial, that's in the patients who are still alive and undergo a cystectomy, right? So if you die of a disease with metastatic disease or failure of treatment, and in this case, we're talking about radiation, for example, chemoradiation, if that didn't work and the patient died before he or she could get a cystectomy, they don't count towards that cystectomy rate. So it's always good to keep that cystectomy number 14, 12%. It seems impressive, but you got to really look behind the scenes and take that with a huge, not a grain, but a tablespoon of salt.
Yeah, that's a great point. And of all the people that do end up undergoing cystectomy, what proportion of them underwent cystectomy for disease reasons rather than toxicity-related reasons? Now, maybe you could take that. I see you nodding.
Well, the point I was going to say, actually, Renu, is about the patients who didn't get the cystectomy. And when we look at the difference in the development of distant metastases in that group. And then I think this is where understanding who got neoadjuvant chemotherapy, who didn't, because remember this group actually just about a third of patients did actually have planned neoadjuvant chemotherapy. And so I'm particularly intrigued by, of course, what went on in the natural course of disease for those patients who did have recurrence and then did not get cystectomy and the distant mets development, because we didn't seem to make as much of a dent in that as we would like. And I think that's where there's still clearly a lot of inroads to be made. And I'm always curious what my colleagues think about in terms of, either chemotherapy intensification, immunotherapy, or is this something that we wouldn't have had they gotten cystectomy? So that, just to be provocative, is that would we not have seen that distant met? Can we actually say that? I don't know that we can.
Yeah, it's tricky. I mean, if you read through the paper, it sort of writes off and says, well, those that failed early were metastatic and we were never going to get them. But I mean, you can say that in follow-up, but in reality, we wouldn't know because you'd have to have a randomized trial, which we don't have. But I was just going to follow up on my favourite words of radiation, so hypofractionation and dose escalation. Now, Professor Shomik Sengupta, who some of you might know, we did a study a few years ago. We were trying to put together lipiodol with various glues and things. Could we actually target the tumours better for the radiation oncologist so you can actually dose escalate those areas? And I noticed that some of the patients here only had partial bladder treatment and so on. We did a trial and published it, but it wasn't that easy to get a marker. We thought about gold seeds, they migrate, so on. Do you think it would be better if we had a marker that you could focus on where we could circle the tumour, or do you think that the targeting using, say, MR, which has got a little better in the last few years and so on, does a good enough job for you from a radiation perspective?
Yeah, great question. I think nowadays, because of the technology, just as you mentioned, we have MR-Linac as linear accelerator is one example. I don't think the markers are as critical. There was a time not too long ago where the presence of those fiducial markers and knowing where the urologist had been and what they'd seen when they were doing the cystoscopy and the TURBT was so critical to leave those markers behind. But I think less so now, as long as we have sort of a map and a sense of, where the lesions were, and with solid imaging, I think we're able to overcome that. What's interesting though is whether we need to do this. I think this was certainly designed more as a toxicity question. The second randomization in the trial in BC 2001 that had to do with whether doing the partial boost and reducing dose to the rest of the bladder made a difference in toxicity, but it was designed as non-inferiority from a control standpoint. And I don't know that we got any clear answers there other than either is acceptable, but I don't know that we've given up or we should give up on continued focus, particularly for lesions that are quite limited. Any bladder sparing that's possible, I think is still always worthwhile, regardless of the negative findings here.
Well, I mean, Declan, great trial, isn't it? And great to have long-term outcomes. But Ashish, this obviously this trial doesn't compare between bladder preservation and cystectomy. And I think, what a lot of urologists will want to know when faced with a patient who has muscle-invasive bladder cancer is how do you choose? How do you handle that question and what will future trials look like?
Well, so I think it's very important for anybody that treats patients with bladder cancer to offer them the option of radiation therapy or bladder preservation if it's appropriate, right? And that big if it's appropriate is where you'll see a lot of our colleagues say, oh, I don't have any patients that are appropriate. And hence, that's why I don't recommend it to anyone. And I think that's wrong because in the right patient, chemoradiation certainly has a role, right? And what I usually recommend in programs that are starting out is follow the classic Bill Shipley teaching, the single tumor that can be easily reached, where the bowel's not overlying the bladder, where you don't have hydronephrosis, no CIS, good bladder capacity, et cetera, et cetera. Those are the patients that you should start out with. Obviously, we and others have experience where you can have multiple tumors in the bladder, so long as you can. And again, I tend to debulk most of these tumors. I know Nick James over in the UK feels that you don't need to debulk any bladder cancer. You can go straight to radiation therapy. He and I have had multiple debates in person and on Twitter, and he hasn't convinced me. I still think we need to debulk as much of the disease as we can to get chemoradiation to be effective. And then there's a wider range of patients that actually can get chemoradiation. And Neha, I'd be interested to see what you have to say about this, because I actually just put out a honest question on Twitter recently, because I was getting a lot of pushback from radiation oncologists saying, oh, the tumor is too close to the sigmoid, we can't do radiation. It's too close to a small bowel, we can't do radiation. And I know our radiation colleagues in GI radiate the bowel all the time. So, do you tend to turn down patients, for example, just because of the location of the tumor, or will you do dynamic modeling and dynamic, simulations for these patients?
Good question.
Yeah, thank you for the question. I would say that as with many things, and perhaps this applies to surgeons as well, it all comes down to sort of the confidence of the experience. I think there's what we all read in the books and the classic Shipley protocol that was described very well earlier with the mid-treatment second look. So it's very conservative, as it needed to be, right, historically, to prove the worth at that time, because we didn't know if it was at all feasible. Now, fast forward all these years, we have all these technologies. You're still going to find radiation oncologists that would shy away from anything that exceeds, our small bowel doses. We usually try to keep even point doses, maximum doses below 54 gray in our units of radiation. And, most bladder cancers we're trying to treat in the 60s. And so there's often this concern. And if there's a willing urologist and an eager patient who's fine or has ambivalence either way and is willing to do what the doctor says, I can see a tendency to say, oh, unless it's perfectly cherry-picked patient, I'm not going to radiate. But I think for most high volume centers where we have radiation oncologists that are accustomed to challenging cases, multidisciplinary tumor board discussions where the patient, the urologist, and the radiation oncologist have all decided we're really going to give bladder preservation a solid attempt. I think we have now the tools to work around pretty much almost all of these restrictions. I'm still not, I know I've seen it on Twitter that hydro does not phase some of my colleagues in various parts of the world, but we do each have our own criteria. But as far as the location and some of those restrictions that you mentioned with the sigmoid, I think we have the tools now to work around it. And particularly if you have a patient with minimal tumor bulk and obviously, minimal number of lesions, very limited CIS, and you can stay away from those areas of the sigmoid. I think we've just learned that you could make that area cooler and not necessarily gain or lose, any success points and not worry about the toxicity as much.
And Nathan, over to you. You're a resident bladder cancer expert. How are you going to use this data and how are you going to choose between bladder preservation and cystectomy for the next patient you see?
Good question. I'm not sure I'm the expert, but I certainly take an interest in it. Look, I think it's a case of, I'm with Ashish. I think you've just got to consider each case. And, we do put forward, I agree, we probably put forward more cases here for chemoradiation than ever. And we do get a little bit of pushback as well at times about bowel location and so on and so forth. I think the other issue for us here at Peter Mac, and maybe it's just the cohort we get, we often have patients who've previously had radiation to the pelvis for bowel cancer and other gynae malignancies. So, again, another group who are not, I've got a lady at the moment who's had endometrial cancer many years ago and now probably got a secondary malignancy, unfortunately, from that original radiation. She's lived long enough and done well enough into her late 60s to get that. So I think that's an interesting aspect as well that we probably won't have time to touch on today. But getting back to your original point, I think it's probably just having the confidence that, and this sort of data adds to it, that we can actually say to patients, look, there's good long-term data. Ignore what you read on Google. We know through our trials we've published that probably only about 15% of Google pages will give any sort of semblance of reality to treatment. We know that across all urologic malignancies, and that's been shown time and again. So I think it's really, it's about setting the patient expectations. And, you know, I think the difficulty comes when we know a patient's not suitable for bladder preservation. They've read bladder preservation and want it. And then we have the other way around where patients go, I want my bladder out. And I'm like, well, actually, you know, you're 84. You know, you probably might do okay with chemoradiation. So I think, you know, you've got to reset those expectations from the patient just as well as we've got to set our own for who we can choose. So, you know, this data will empower us, I think, to have those discussions in a better way.
Fantastic. Well,
I think Nathan has to run, I think.
He's
Nathan,
got better things to do than content creation on a Thursday morning.
Exactly, but thank you very much.
Good luck with the penectomy, Nathan.
Thanks, guys.
Thanks for joining us.
Good to see you, Nathan.
Pleasure to be here. Cheers. See you guys.
Fantastic. So Nathan's heading off, but we still have you guys for a couple of minutes. There were two other quick things we want to talk about because recent ESMO, I know none of us were actually at recent ESMO, but there were some advanced bladder cancer highlights, but we wanted to focus today more on local, regional. And there were a couple that caught our eye, Renew. One was Nick James, and we actually, as we were having the previous discussion about debulking, etc., it's very relevant to talk about this paper he presented called Bladder Path, the Bladder Path study, which he's been talking about for years and years and years. Quite justifiably, like many people, criticizing the way we manage primary bladder cancer, that TURBT is a bit of an arcane, imprecise procedure, etc., etc. And he and others have had this idea that why don't you do an image-based approach and do an MR of the bladder rather than a TUR of the bladder, and then see which pathway might be better. So he presented the Bladder Path study, and I can see both of you have been tweeting about it, and we'll put links out in the show notes. But this is
great because it's what made this podcast. All those tweets.
Yeah, well, exactly right. Yeah, that's all we do. We just look at Twitter and think, what are we talking about this week? But it is provocative, isn't it? Because well, maybe we'll have a quick chat about it. A randomized study where you take men newly suspected of bladder cancer based on a flexible cystoscopy, and it's about the pathway. They're either on a pathway where you go to the OR, have a TURBT, and then whatever definitive treatment, whether that's endoscopic for non-muscle invasive or radiotherapy or surgery for muscle invasive, the pathway to when you start that versus versus an imaging based pathway. So you have your flexi, but then instead of a TURBT, you have an MR, and the MR is to characterize this lesion, and whether MR alone can correctly characterize muscle invasive is one of the questions that gets addressed, and ultimately what treatment they go on and get. So Ashish, you've been talking about the value of debulking, etc., and I could see a lot of people on Twitter reacting, saying, hold on, you know, there's a lot of value in it, the pathological variants, etc., the CIS associated. So what your thoughts on the Bladder Path study? And maybe we will get you and Nick back on, because I know you've debated it before, but now that he's presented it, maybe we will invite both of you on, and he's an old friend of the podcast as well.
Yeah, you know, so first off, I know Nick and we're friends, and I like him a lot, and I have to give him, you know, due kudos for actually designing the study and getting it going and rolling and publishing on it, as he's done with many other studies that he's done before. But if you really look at the genesis of the study, and the primary endpoint is the time to getting the patient to definitive treatment, which is a problem in the UK, as we all know, right? I mean, a patient gets referred for hematuria, they get diagnosed with potential bladder cancer. By the time they get the TURBT, that's what the quality clock is on. But from the time of the TURBT to when they get to actual definitive treatment, whether it's radiotherapy or whether it's surgery, that can sometimes drag on for 6 to 12 months. So what he wanted to show was that if you skip this big hurdle of TURBT, can you get the patient faster to definitive therapy? And there he's won. I mean, there's no question about it. If you skip the TURBT, you get to definitive therapy. But the issue is faster or better, right? Are we actually improving the outcomes of these patients? And if you look at that, we don't know yet. So this trial does not tell us whether you can actually predict the bladder pathology, even though it's called Bladder Path. It doesn't tell us whether the outcomes of the patients are equivalent. Yes, they get there quicker, but do they do better? We don't know that. And I really think that, you know, MRI is here to stay. And especially if you have standardized MRI protocols at your center using the VRADs, it's much more reliable than CT scan, which, as we know, is worse than flipping a coin because you're wrong more than half the time when you're trying to say T2 or T3 with a CT scan, right? So MRI is here to stay. Bladder Path's great in situations where you don't have access to healthcare in a rapid fashion. But I suspect you, Declan and Renu, where you are, you see your patients, get them to TURBT and cystectomy in a timely fashion. And as urologists, we've published numerous times that getting patients to definitive therapy between 8 and 12 weeks is that time point beyond which you can affect outcomes. So in a system where you can't do that 8 to 12 weeks from diagnosis to cystectomy or radiotherapy, yes, skipping TURBT makes sense, but otherwise you're giving up the variables such as small cell carcinoma, right? How do you know it's not small cell, which is clearly a systemic disease? How do you know if they have LELC? How do you know if they have variant histologies? You don't know a lot of things if you skip the TURBT completely, and you're sacrificing maybe a small percentage of patients, but I don't want to sacrifice any patients, right? So I think we need to look and see what the data shows when it comes to outcomes, but clearly he's shown that you can get there quicker.
Yeah, I mean, that is significant, isn't it? For those who are not familiar with it, the use of this MRI-directed pathway led to a time to correct treatment of 53 days compared to 98 days for the traditional method.
Yeah, so the message is on a trial, if you skip a TURBT and just do an MR, you'll get onto the treatment quicker. Which that makes sense. And I suppose it's important that in the standard pathway, they still got there in 8 to 12 weeks anyway. But that's in a trial. So I think maybe the point is that in community settings, maybe not everyone gets there in 8 or 12 weeks. But I think, as Ashish has said and others have said on Twitter, yeah, but is it leading to a better outcome just because you get to the pathway, a few weeks earlier? All the extra nuance you get with a bladder tumor. But what about you, Neha? What do you think about treating a patient without histological proof of muscle invasion? Is that something that you would embrace just based on getting there a bit quicker?
Well, first thing I'll say is, again, kudos to Nick James and his whole team. I think when you think about disruptors, right, disruptors in science and in technology that sort of get us thinking in a different way and thinking about the next thing, he's certainly a master of that. And I think what is appealing about this is this idea that how do we incorporate imaging? I think that since the tweets first started, I think Nick has acknowledged, yes, there are patients in whom absolutely the TURBT makes sense, and particularly when you have extensive CIS, the variant histology issue, all of that. But I wonder if, again, as our imaging improves, as other markers, potentially urine cytology and other markers may improve, how would we incorporate that so it isn't a one-size-fits-all, that every patient would necessarily need to go through the TURBT? And I think, Ashish, to your point, I mean, obviously you're very thoughtful about the patients in whom you do a more extreme TURBT down to the fat versus more of a debulking. But, I think what often happens, at least for a lot of the patients we see who might be referred from centers that don't get a high volume of this, is you get a variable quality of TURBT, you get significant, potential post-procedural infections and toxicities that really set the patient back. So while it is true that I think there are environments in which patients generally don't have these delays, even in areas where there shouldn't be a delay, there might be because of some unexpected morbidity. Again, it's not to say that obviates the need for the TURBT, but I think it would be, for many of us, pretty exciting if there could be a pathway, again, for selected patients where you knew that you could safely forego a more extensive TURBT if you felt that the Likert score, for example, validated on the flexible cystoscopy, and then perhaps with long-term follow-up, and we see the outcomes of how these patients do. If we find that they fare well, and that is the big question, how will they fare? We have yet to see. But if they do, I can envision a paradigm in which this gets incorporated. Again, I don't see it replacing TURBT. I think there'll be a lot of steps before that could ever happen. But I love the idea of, again, the disruption and just sort of thinking in a novel way. And I think we're all pretty open to that.
And if I could just follow up on what Neha said, I totally agree with you about the quality of TURBT and a plea to Renu and Declan and GeoCast. You should have a dedicated session on TURBT because that is the most neglected technical procedure that we need. I mean, it's the most important thing that we do for patients with bladder cancer, but everybody focuses on, for example, robotic cystectomy, right, which is the least important do for patients with bladder cancer.
Yeah.
But you're right. I mean, I'd rather see this replace a poorly performed TURBT than have patients undergo poorly performed TURBTs, because you get complications, you can get perforations, seeding, all of that. So if we can get rid of TURBTs that are not done well, absolutely, I'm all for this. But a well-performed TURBT, I think, is still a very critical part of the management paradigm of our patients. So I think there's a role for both, and maybe we could, flip this around and say, well, if you're not a good resectionist, put your patient on Bladder Path, and if you do it well, resect the tumor.
Absolutely. I mean, you can definitely see those implications for something like this, disruptive technology like this, Neha, because like you said, Declan, so a community setting. Maybe this will prompt earlier referral to a tertiary setting, based on an MRI-directed pathway. But
and the point about TURBT is so right, because it often then gets left to a more junior urologist, a resident doing this or doing the repeat one, et cetera, and it is the most important thing to get right. And good idea. Fantastic. We'll park it away. We'll get maybe someone like Tim O'Brien, who has a big interest in TURBT technique, to come on as well. And there are a lot of improvements in technique with en-bloc resections and using image-assisted, BCG, Hexfix assisted, et cetera, et cetera. But look, that's great. We are, I think, pretty much out of time, are we?
Yeah, there we go. Bladder cancer being disruptive.
Yeah, it's great. We should do more bladder cancer, shouldn't we? Every time we talk about bladder cancer, it's very popular. We talk about too much prostate cancer on this podcast. I know we do, but it's hard to avoid.
She's given us an idea. TURBT, that'll be on our list.
Yeah, but we
did. You guys were so kind.
Yeah, the prostate's just there. It's in the way of the bladder. I don't know why you guys focus on the prostate.
There he is at MD Anderson fighting his own.
That's right. And I didn't even need my body armor. You guys were so kind. Thank you. So I take it back. No complaints.
Super diplomat. And by the way, we got great feedback from last week's post about radiation and renal cancer. People love that. So, and we're going to do a lot more renal cancer in the next few weeks, because ESMO was all about renal cancer, wasn't it? It was absolutely fantastic.
What a great platform for renal cancer this year.
Fantastic. Well, look, I think that's where we'll call a halt to it, and we'll wish everyone all the best. Thank you for joining us so much, Neha and Ashish. You're great friends of the podcast, and we look forward to having you back again sometime soon. That'd be great.
Thanks for having us.
No problem.
Thanks
and
so much.
That's it from you and me, Renee.
Yeah. Until next time.
We'll be back again soon. And if you've got suggestions for content, of course, we're always interested in hearing what you want to listen to on GUcast. So just email us or send us a message on Twitter. It's very easy to find us. Thank you very much, and goodbye.